Welcome to today's edition of Musical Chairs. When the music stops, please be seated. 2, 4, 5, 6, I think. Call to order the meeting for the Health and Human Services Oversight Committee for today, which is November 21st. And the chair has asked, and the representative Lamontagne has graciously accepted to be acting clerk unless Representative Weber arrives. And would you please call the roll of who's here? And do you have your microphone on, please?
Take the minutes of the last meeting and look at the members' questions.
Yes.
That's an engineer's mind. He's really good about that sort of thing.
Representative Pearson,
Here.
Senator Gray, Senator Rosenwald is not here, Rep. Weber is not here, Rep. Woods, Rep. Seward,
Here.
Rep. McDonald is not here.
Has given me an excused absence this morning.
Yes, and I believe Rep. Weber, I'm sorry, Rep. Senator, I'm sorry, Rep. Mooney. Rep. Mooney, I apologize.
Here.
I think we have a quorum.
Here, Noosa.
And we have the minutes from the last meeting. The chair will entertain a motion.
But I would also add that Rep. Weber, I think, sent a last-minute email that she's unable to attend.
Okay, so
for
she
several
is
reasons,
excused, and thank you.
Move to accept.
Second? Any further discussion on the minutes?
I'm going to abstain, Mr. Chairman, from the October 24th vote as I was absent.
Duly noted, thank you. All in favor on the minutes?
Aye.
Opposed? Okay, DHH Commissioner's update and Commissioner Weaver. I got somewhere to go at noon.
Good morning, Lori Weaver, Commissioner HHS for the record. I do have a guest with me as there was a request, I believe, on the update. I thought before I hand it over to our Director of Public Health, Ian Watt, that I would just give you a little bit of an update on what happened with our Rural Health Transformation Grant submission, if the committee would be interested. Okay, great. So on 11/4 at approximately 9:37 p.m., we submitted our grant. It was due on 11/5, so we were a little bit early, which is great. We have posted on our website. We have a document that summarizes everything that was in the application. The application itself is onerous, dense, and multi-document. So what we did is we took all of the meat of it, if you will, the proposals, and have a summary on there so that you can see. And that's reflective of everything that I would say everything, like 99% of things that we heard from the communities. So we met with our partners, we met with constituents, we met with various agencies, providers throughout the entire state. We did a request for information to be able to say, what are your thoughts based on these goals of what we have to do? I say 99% because there were some things that are just not allowable. So even though we had some really great ideas, the grant does have parameters that will not allow some of those things. But pretty much we have captured the voice of people of New Hampshire in our proposal. In the next week or so, we will be in engagement with CMS, and it's an open discussion time where they will then ask us questions about our grant. We will provide answers. We'll do a little bit of editing and massaging based on their feedback on our proposal, as well as some budget negotiations. So the budget components of it are really sort of just doing your best guesstimates when you do your submission, and it's really getting down to the brass tacks with CMS of what that budget is going to look like. So we won't know anything formal. We'll know on December 31st what they have approved and then what they've approved for a budget. And at that point, we head north. It's called Go North, and Go North is our administrative infrastructure to administer the grant, and it's based out of the governor's office. It is not the brother or sister of Gopher, one may be confused. It is a similar entity, but they are separate grants. The funding sources for ARPA and this grant are different, so there'll be some differences, but at the end of the day, the similarity is that the governor's office has direct oversight of the grant and working in co-leadership with myself and my staff at HHS to administer the grant. So once we are given our award, you will see a mad dash from like January to March to move to procurement for a lot of the proposals that are in there. So that means probably fiscal will be quite busy, as well as governor and council, as those are the approving entities for that. We also will have to accept and expend the money before we can move into contracts, so we'll be at fiscal for that as well. So there's a lot still to get done, but the good news is we got our grant in on time. We're very excited that it represents the voice of New Hampshire, and we'll see what CMS allows from that.
Will you take any questions on this?
Oh, is that a choice?
Yeah. Actually,
sure.
no. You will take it.
Happy to take questions.
Will some of this grant money help you with hiring to positions that maybe right now there isn't funds for?
Yeah, that's a great question. It is allowable through the grant for us to be able to hire positions just as long as we don't go over our administrative 10% rate. So it is the intention to be able to hire some positions, and then also some of my staff will have dual roles in helping administer the grant, but we are going to need extra hands for sure.
Any further questions? Well, thank you for that update very much.
Okay. Thank you.
Not on that subject, but on the budget subject. How are we doing with the back of the budget cuts and things that are going on? So you don't have to answer that one now, but I want, as we go through these meetings for Health and Human Services Oversight, I want that to be a topic that we visit on a regular basis of how you're doing.
Yes, absolutely. I know we do have later in our agenda the opportunity to talk about the budget, including your question, but I will at a high level just say that, we started July 1 to address or try to address our back of the budget cuts, and we're continuing to do so. We've made significant progress for fiscal year 26 and trying to work on 27, but it's a large number, so it takes a lot of creativity and innovation to be able to get there. So, but we can talk more when we get to that part in the agenda.
Senator, the agenda speaks of a quarterly update. Are you asking for more frequency?
Again, I guess I want the department ready to speak at any meeting when we have questions. Certainly the report quarterly, helps, but, there could be issues that come up in between those quarters that we may be able to help with or hinder, I guess.
I'm trusting that if you see one coming, you'll alert them ahead of the meeting as much as possible.
Of course.
Oh, we stand at the ready to discuss it whenever you would like, Senator. So it could be here or at fiscal and subsequent meetings.
Thank you.
Thank you. And thank you, Chairman and Committee, for having me here today. For the record, my name is Ian Watt. I'm the Director of the Division of Public Health. The committee requested that the department appear today to share information on the status of vaccines in New Hampshire related to any changes at the federal level. The Division of Public Health is committed to maintaining access to safe and effective vaccination for New Hampshire residents and families No, there was no handout for this presentation. I'm just going to.
That's the budget for the budget.
That's for the budget. Sorry about that. So we remain committed to maintaining access to safe and effective vaccination for New Hampshire residents and families who wish to pursue them and protect themselves against vaccine-preventable disease. We maintain this focus through various activities, including the state's Universal Purchase Program, which provides access to free vaccines for children whose families wish to pursue them. On September 5th this year, we issued our annual guidance for providers in advance of respiratory virus season. There was a focus on maintaining access for individuals and families that wanted to pursue vaccination for flu, RSV, and COVID-19 in consult with their doctor or pharmacist. The guidance enables any individual or family seeking to get immunized to have access through their provider or through their local pharmacy. We also specified vulnerable populations in that distribution that may be at particular risk, including seniors, pregnant women, and anyone who is immunocompromised. Regarding specific federal developments, in September, the CDC modified its recommendation for the measles, mumps, rubella, and varicella vaccination series. It's routinely recommended as a 2-dose series with the first dose at 12 to 15 months of age and the second dose occurring between the ages of 4 and 6 years old. Prior to the federal change, sure. Oh, sure. Is there anything you'd like me to go back to that I've? Sure. So the CDC modified their recommendation regarding the measles, mumps, rubella, and varicella vaccine. It's routinely recommended as a 2-dose series. The first dose is received at 12 to 15 months of age, and the second dose is received at 4 to 6 years of age. Prior to that change, there was an existing, quote, preferential recommendation for separate shots in the first dose. That would be the MMR and varicella as 2 different doses because of an increased risk of febrile seizures when using the combination MMRV vaccine. The updated guidance does not recommend the combined MMRV vaccine for the first shot in children under 4. It's notable that only about 15% of children were getting that first dose as a combination vaccine prior to the recommendation, likely due to the preferential recommendation. The combined MMRV vaccine is still recommended for the second dose. We will continue to monitor federal developments regarding vaccination as well as conduct ongoing review of best available evidence-based medical guidance to ensure the safety of our residents.
I remember during the pandemic, I was chairing something or other, and Commissioner Shibanet told us that, and pardon me for giving you the liberal arts and not precise narrative, there were 17, 18 different vaccines the CDC might strongly recommend for public school children, but New Hampshire was very much on one side in that we only would mandate 9, roughly. We were very much on the cautious side of mandating. Has that changed?
So imagining that was in the last 5 years, the childhood vaccination schedule and required vaccines for school children would not have changed. To your point, we take a really critical eye to federal recommendations and what should be mandated and required for school children. We do have 9 vaccines mandated for school children and 10 for childcare. So that's something we have conducted review on an ongoing basis, but have a pretty stable set at this point.
But some states go much higher than that.
There is a higher list of requirements in other states as well in their federal recommendations.
This is important to know in the ongoing discussion about vax and anti-vax, that New Hampshire is very conservative on this.
We certainly always take a critical eye to what's necessary and what's going to be necessary to protect families and the communities in our schools and child cares. We look at our evidence-based science, we look at the data. I work closely with Dr. Ben Chan, who's our state epidemiologist, to review all available medical science and data and make sure that we provide only what's necessary for families to be protected.
Having gotten the number right, are these mandated? In other words, if you are going to public school, unless you have a very distinct opt-out, these are mandated for public school children?
So specifically the respiratory virus that we gave guidance on in September are not mandated. They would not be part of those requirements. MMRV is a requirement for school children. And there are exemptions, right? There are statutorily allowable exemptions for religious reasons or other reasons. And there's a process. It's laid out on our website, and it's possible for people to be exempt with the right fulfillment of that, providing it to their school.
Are the mandates that are in place, with exceptions for public school, the same for charter schools?
That's a question I actually don't have on the top of my head. The answer is yes. Thank you. I use my former director of public health as a good resource when I can.
Thank you. Any further questions so far? Representative Woods, thank you.
This is sort of a sidebar, but there's been some discussion about the funding of these vaccines and their availability. Has there been any involvement from your perspective about having them available? It's one thing to mandate, but the other part is availability. Is that impacted, or have any thoughts on that regard?
So there haven't been any changes at the federal level in terms of which vaccines are included in the federal vaccine for children program, which is really critical to maintaining access here locally.
I was thinking more state mandates in terms of funding.
Yeah, so there certainly has not been an issue with supply and our funding related to it. Again, the federal funds are the bulk of what funds and really what's allowable within the federal program is going to dictate what we're able to purchase. So as a result, we're able to continue. Associate Commissioner, you have something to add?
Patricia Tilley. Thank you. Patricia Tilley, Associate Commissioner. Thank you. And I apologize for jumping in, but I think your question, Representative Woods, is around the funding for childhood vaccines in New Hampshire, which we do through our partnership with the commercial insurers. And that funding is still intact.
For the moment.
For the moment, but today it is still intact.
Thank you for your time. I appreciate it.
Good, thank you. Thank you for coming, folks. Quarterly budget and staffing update. That's this one, thank you. Oh, yeah.
Good morning, members of the committee. Nathan White, Chief Financial Officer with the Department of Health and Human Services. Before you, I've handed out the document, as it looks like everybody has identified. This is a brief overview of the agency budget and our vacancy rates. And so what I'll be focusing on today is the general fund projected lapse that we currently have identified, as well as the vacancy rates. If you turn to page 2 of the document, I just wanted to provide a very brief overview. I know that some of you do work within Senate Finance, others are not a part of those committees. So just to kind of level set, broadly what you see here on page 2, this is a 60,000 foot view of the statewide budget. And you'll see in the pie graph on the left, this represents the total budget, all funds. And HHS is about 44% of the total operating budget. The pie chart on the right, this represents the general fund portion of the statewide operating budget. And you'll see that Health and Human Services is approximately 56% of the total general funds. If you turn to page 3, we'll dive a little bit deeper into the overall HHS budget. The two graphs there, the first is for state fiscal year 26 and the second is for state fiscal year 27. And the blue box you'll see is the federal funds, which represents about 50% of the dollars within the DHHS operating budget. And then the teal represents the general funds, which is about 31% of our total budget. And then the remaining amount represents other funds that comprise our budget, and that's about 20%. So just to kind of level set, the general fund lapse will only come from that portion of the teal box of our budget. So about 31% of our total budget has the potential to lapse back to the general fund. If you turn to page 4, This is the page that shows us, the graph on the right side shows us the general fund lapse projections that we currently anticipate. What's really important to understand when thinking about the general fund lapse is that for HHS in particular, it is difficult and very complicated to project the lapse because there's really a multiplicity of factors that go in there. HHS, unlike many other state organizations, a little over 10% of our total budget is actually personnel. And personnel expenses are generally pretty easy to project. A lot of our budget, though, is driven by utilization, and we're not necessarily able to control all of those factors. But what we do on a monthly basis, we look at every accounting unit, and we look at every class line, and we look at what we've spent year to date, and we analyze that, and we look at future commitments that we're anticipating or other factors. And we look at that, all the detail, and then we roll that up each month to come up with a projection. And so what you'll see in the chart is beginning in July, based on only 30 years of spending data, we were looking at about $24.1 million in total general fund lapse. And then each month there, you'll see that there'll be some fluctuation. And that fluctuation can be the result of a contract being terminated. It can be the result of a couple of retirements if we had staff that worked for the department for 30 years and we had significant payouts for their retirements. Things like that that we can't necessarily anticipate will cause that number to fluctuate from month to month. So right now, we're currently looking at just shy of a $20 million total general fund lapse. Within the state's surplus statement, which represents the document that the state and the legislature passed their budget with, it shows what's the total lapse projected for state fiscal year 26. I believe that total amount is around $39 million. Traditionally, HHS is often looked to for about half of that. So currently we're running around right on par with that figure. One thing to understand too on page 5, if you go ahead and turn to page 5, is one of the unique parts about HHS's budget is that state law specific provisions prohibit certain funding sources from actually lapsing. So of that little over $1 billion of general funds that we have budgeted each year, in the first year of the biennium, only about 33% of that can actually lapse. And I've listed a few of the programs there on the left that have specific statutory provisions that either make those funds non-lapsing in the sense that they will never lapse back to the general fund, or they may just not lapse back in the first year. And then there's other unique areas where if there's any money left over at the end of the year, a payment is made to the appropriate parties. So there's many wrinkles within our budget that kind of feed into why only 33% of the total general funds lapse at the end of the year. And so as a result of that, what you'll see in the first year of the biennium for the Department of Health and Human Services is you'll see a smaller lapse. And traditionally it's about a third of what you would see in the second year of the biennium out of HHS's budget. And the LBA, they account for that factor when you look at the statewide assumptions. There's always a much higher general fund lapse assumption in the second year of the biennium. If you turn to page 6, this provides an overview of the current vacancy trends that the department has seen over the past year. And it begins in December of 2024, and it goes right up through about November 17th. It's not the complete, or not November, yeah, about November 17th. So it's not the full complete month, but it's as accurate as we currently have. You will see a general trend upwards, and there's a couple of factors that go into that. One is we saw just shy of about 400 positions that were unfunded in our budget for the current biennium. And so we have a little over 3,200 full-time authorized positions, and about 400 of those were unfunded. So that resulted in about a $30 million total general fund reduction across the biennium plus matching federal funds in many cases. The hiring freeze has also been something that the department has been managing. We've been prioritizing our direct care to ensure direct care, meaning child protective service workers or New Hampshire hospital staff, to ensure that those critical services can continue. But globally, overall, we have seen that trend move upwards through November of 2022. And I'll
I just wanted to add, just based on your question prior, on the back of the budget cuts, so we know what we're expecting to lapse, but we also have a pretty unprecedented, sizable back of the budget cut as well, and a 14% budget that we started out of the gate with that was less than what we've had. So, when you factor all that in, I don't know if lapse is going to look like it does in typical years. So I just want to, we're sort of in a little bit of a different time this year where we're hurting at every single angle.
Senator?
And that's part of my problem, okay, is that the back of the budget cut is a mandatory cut. I mean, it's got to happen or something else needs to meet it. But a lapse isn't, okay? So, those are going to play with each other right now. And so my own personal opinion is that you're going to work hard to make the back end budget cuts, and your lapse may not be anywhere near what it would normally be.
Did you want a specific response, Senator Gray, or?
No, my
Okay.
nodding was a
Okay.
yes.
All right. That is all I have for the presentation, unless there's further questions.
I guess if the chair would allow me,
Proceed, Senator.
the answer really shouldn't come from you. It should come from the governor's office and their budget people. Is how, because we're not the ones that are actually going to be giving you any direction at all on what to do, but they are. And they need to understand that relationship between trying to make that back in the budget cut that originally came from their office and how that affects the lapse and how we're going to end the budget on a positive note. And the preliminary numbers for October on revenues are in the toilet. So, I get concerned. The last time I raised that, they said, oh, December is going to be a good month. Okay, so thank you.
Thank you.
Thank you, folks. Permanent Subcommittee on Alzheimer's Disease and Other Related Dementia Annual Report.
Thank you, Chairman Pearson, members of the committee. For the record, my name is Jenny Horgan, and I am the Senior Public Policy Manager at the Alzheimer's Association, and I serve as a member of the Subcommittee on Alzheimer's and Other Related Dementias, and I have a guest with me today.
Hi, I'm Maureen Murtaugh. I'm with the New Hampshire Board of Nursing, and I am on the subcommittee.
Great. So just to start off, I know that I have the very bad habit of talking very quickly, especially when I get going. So Representative, please feel free to interrupt me at any point in time. I want to first acknowledge the incredible work of the subcommittee this year, all of their members, Chairman Avard, Representative Leon, and all of our other great members on the subcommittee. We've really started to feel like we're making some traction on our duties, so we're really excited to present to you today our annual report. Obviously, this work is incredibly important. We have over 26,500 individuals living in the state with Alzheimer's or dementia, and over 48,000 caregivers that are supporting them, along with all of the professionals and state workers that are offering supports to this community as well. So since we last presented to you, the subcommittee has roughly met about 6 times, and during those meetings, we had a number of presentations that were incredibly informative to us developing our understanding of the landscape facing individuals living with the disease, as well as their family and loved ones. We also had a number of robust discussions about those challenges that people are facing in the state. So to give you a very brief overview, because I know Chairman Pearson, you've got a 12 o'clock meeting to get to, we had presentations from the department from Wendy Altman at the Bureau of Adult and Aging Services that gave us an understanding as to the services and supports that the state currently offers on multiple levels, as well as a presentation from Fish and Game and the state police regarding the process for a silver alert. We also had Wendy present on the completed brain health awareness campaign that the legislature funded in the previous budget and was running from January to June of this year, and then a presentation on palliative and hospice care for people living with Alzheimer's and dementia in the state of New Hampshire. In those discussions that we had along with those presentations, as I said, we talked about the challenges and gaps that we see presenting for people living with the disease and their families, and we began to review the state plan on aging, or the state plan on Alzheimer's, that was last updated in 2015 and 2016. So that's where we really started to get some traction going, which is really exciting. One of our charges as the subcommittee is to develop a state plan on Alzheimer's. And so the subcommittee decided that an effective way to try and get our hands around this very large comprehensive issue would be to develop a needs assessment survey that will be sent out to people living with the disease, their family caregivers, and those offering supports and services across the state to get an understanding from them directly what challenges they're facing, what their most prioritized needs are, and all of that. So we decided to form a work group, a needs assessment work group of the subcommittee members that met a number of times. You'll see the minutes from those meetings in your packets as well. And so they've been working very diligently on developing that survey, ensuring it's appropriate, ensuring it's going to give us some really valuable information that we'll then collect. Hopefully, we're working to get that approved by the full subcommittee at the beginning of next year, and then send it out, pull together other data sources that the state and organizations have, and then utilize that to hopefully develop our state plan on Alzheimer's to present to you at our next annual report. So that's a overview of what we've done. Our recommendations for this year, you'll find that our recommendations align very nicely with the recommendations from the Brain Health Public Awareness Campaigns report. So we have 4 recommendations that we're advising on for this year. So the first recommendation would be that the state should integrate materials into the state's chronic disease prevention, aging, and public health outreach programs surrounding Alzheimer's and dementia to promote brain health and reduce risk of cognitive decline, as well as help granted seniors understand the importance of early detection and the relationship between Alzheimer's disease, dementia, and other chronic health conditions. This is deeply important. There's so much new research and information coming out right now that we think is vital for people to understand in terms of the disease, in terms of treatments, in terms of supports and services available to them, as well as prevention. So we're excited to make that recommendation. We also, in a multi-pronged approach to try and comprehensively have the state address Alzheimer's and dementia, want to encourage to ensure the systems alignment by embedding brain health and cognitive decline into our systems of care for aging, as well as the state health improvement plan to ensure that the state recognizes the public health aspects of Alzheimer's and dementia and integrate it into that work. Next, we recommend that the state look at the importance of adding the cognitive health measures to the behavioral risk factor surveillance system, the BRIFIS, to monitor the long-term impact of Alzheimer's and dementia. We've worked with the department in a number of instances to get the caregiver module included in the latest BRIFIS, the cognitive module in previous ones. So this is another really good opportunity for us to collect data and develop an understanding of how the disease is impacting granted staters. And then our final recommendation is that the state should continue to work with great partners across the state, including the Commission on Aging, Alliance for Healthy Aging, Alzheimer's Association, and other really great supportive groups that are helping to raise awareness regarding brain health, early detection, and to encourage our medical professionals to develop that awareness and information regarding available resources and tools as well. So that's all I have. We're happy to take any questions.
A couple of things. Number
Hmm.
one, the pages aren't numbered, but it looks like the needs assessment that you're talking about is at the very end of the report.
Yes. So then the needs assessments minutes are at the very back of the report. So those just give you an overview of what that work has been looking like.
And under the rubric of never ask a question you don't already know the answer to, some might not. And this is a subcommittee of what?
Subcommittee of the Health and Human Services Oversight Committee.
See, I knew that.
You
but It's
did.
not on the report. And
Oh, it's not.
Well, I don't see it, which doesn't mean
I
it
will
isn't
make
there.
sure that we include it moving forward.
Because somebody might pick up this report and say, oh, it's a subcommittee.
Absolutely.
Of
Very
what?
good point. I
Okay,
will
good.
make sure moving forward we include that. Absolutely.
And page numbers.
And page numbers. You got it, Representative. That's easy.
But this is really a lot. This is good stuff.
We do a lot of really great work. And, like I said, I'm really excited. I think the whole subcommittee is really excited about the traction we're starting to make.
At night, when I'm sitting over in my chair reading law books now, and my wife's over in her chair doing continuing medical education things, every once in a while, one or the other of us will say, wow, and then, of course, that means we have to ask, what do you mean?
Sure.
And it seems that she is reading something about a possible medical, if not whole, then partial breakthrough in Alzheimer's. Am I right?
There's a lot of really incredible research going on right now regarding treatments for Alzheimer's and dementia, as well as the recent U.S. Pointer study that came out regarding prevention. So those preventative steps that you can take regarding your brain health, getting sleep, eating a healthy diet, exercise, managing high blood pressure, diabetes, all of these things that can have a really huge impact on your risk of developing Alzheimer's and dementia. So that's embedded in the public awareness that we're working to do here and that the department's been working on with the campaign that ran earlier this year.
And what kind of next campaign of publicity on this might you have?
So Senator Avard really kindly is supporting us and filed legislation to require the department to include Alzheimer's and dementia in existing and relevant public health awareness campaigns. We're in active discussions with the department of how to get that language to look the most appropriate way that it can in order to be effective. So that's really focused on building that awareness there. And then obviously all of our partners at the association itself, other partners across the state are always working to build awareness and find more ways to inform people across the state regarding these, the U.S. Pointer study and those preventative aspects, as well as the new treatments, the importance of early diagnosis, because that's when treatments work best, the treatments that we have available now, and the biomarker testing that is, coming out regarding how you can get a diagnosis done. And then as well as those medical professionals, ensuring that they're aware of the cognitive assessments, Medicaid reimbursement for that. So there's a lot of really exciting information that we're working hard with our partners, and the department has been a really great supportive partner in that as well. So we're looking forward to getting the word out there as much as possible.
See, at least one medical provider that I know knows all of these things because these are all required of me in my house. So
well, that's good. We want you to have healthy brain representative for sure.
yeah, if I've announced my retirement from the House in 2049. Okay.
Perfect.
Any other questions? Representative Woods.
Thank you. This is all very good, and it may be sort of buried in some of the details, and I have not read all of the details. I apologize. But given a lot of these goals, it's going to require a lot of increase in the workforce, especially with an aging population. Is that somehow how we can address the workforce problem? Is that addressed in this as well?
It's so we do touch on that in our discussion in the subcommittee. It is not recommendations this year. I think that will really come out in the state plan and the information that we pull into that and present to you in the next year. Certainly the state has a very small number of geriatricians, a very small number of neurologists that are all vitally important to. Yeah, so, certainly we are very aware at the association. I think the subcommittee's had a number of discussions regarding workforce shortages. So I think that that'll really be teased out in the state plan in our report in the next year as we collect that data and really get our hands around what the scope of that issue is.
Thank you.
Wonderful.
Wonderful. Well, we hope you have a wonderful Thanksgiving, and thank you so much for the opportunity to present to you all today.
I have just taken onto the board of directors of the medical center that I chair, a gerontologist.
Oh, great.
So I'm going to snatch one of these and
Absolutely.
give it to
And
her.
please, have him reach out if he has any questions. We're always happy. The subcommittee is working hard, and, the association too. We're always happy to talk to anybody and partner
I'm
with
sure she
anyone.
will. Thank you.
Amazing. Thank you so much.
Happy Thanksgiving. SB 177, report update regarding the use of restraint in the use of different modes of transportation of patients to New Hampshire Hospital or other designated receiving facilities. Wow. Get that on a business card, huh?
Good morning, Chairman and members of the committee. For the record, I am Cynthia Babonis, Chief Community Integration Officer at New Hampshire Hospital.
And I'm Kathy Pizarro-Thunberg, Executive Vice President, New Hampshire Hospital Association. On your agenda is Caroline LaVoy. She is no longer at the Hospital Association, so I'm here representing NHHA.
Okay, for my record here, would you tell me your name again, please?
Kathy, with a K, Pizarro, Bizarro, Thunberg, Executive Vice President, New Hampshire Hospital Association.
Thank you.
And as you said, we are here to present the transportation and restraint data for the involuntary emergency admissions to designated receiving facilities. And the New Hampshire Hospital Association generates this report, and I'm just going to summarize some of the report for you since you have it in front of you, and direct you on page 1 to the year 6 summary stats. Between October 2024 and September 25, there were a total of 1,516 IEA transfers to New Hampshire New Hampshire DRFs with an average of 126 transports per month. This included overwhelmingly adult transports. Children typically are rarely IEA'd in New Hampshire. Over 36% of transports were by ambulance, 61.5% by law enforcement, 1.5% by other means, and 8 unknown. 47% of transports occurred without restraints, 51 with restraints applied before transport, less than 1% with restraints applied at the beginning and then removed during transport, and less than 1% transfer of unknown restraint status. 40% used a combination of types of restraints. 12% used handcuffs only, 46.5% used waist belt only, and less than 1% was of unknown type. On page 3, I just want to bring your attention to that chart, which just outlines that most of the restraints happen during sheriff transport. And then just skipping ahead to the data trends years 1 through 6. The comparison tables below display selected metrics across years 1 through 6. Metrics remain relatively stable, apart from an increase in the overall number of transports, which is in part due to New Hampshire Hospital bringing more beds online, putting beds back online, I should say, and also the addition of a 5-bed unit with Dartmouth Medical Center. The total IEA transport by month displays the total count of IEA transports by type since the beginning. And again, just to underscore that the numbers, the percentages have been fairly stable for the 6 years of the report. Happy to take any questions if you have questions.
I have a question, but I can't form it. So let me just, what are the criteria for making an involuntary emergency admission? I know they're steep and they should be, but can you help me with that?
I don't have the statute 135C right in front of me, but basically someone has to have a identified mental illness that is causing them to be imminently dangerous to themselves or others. I'm not going to summarize any more than that, but that's it in a nutshell.
Okay. And who makes the determination?
of the dangerousness, the IEA.
Yeah.
A certifying practitioner in the emergency room is typically the person who is making that determination.
Can, let's say, one's family practice, PCP, make that as a patient who's presenting with these events?
They, only if they're a certifying practitioner can they sign off as an approved IEA, but they could be a witness on an IEA petition. They just can't be the ones certifying the IEA petition.
Presumably, your PCPs then would have immediately available the name and contact information of somebody saying, I've got somebody here, I'm going to try to keep him here. Can you come and evaluate?
In most circumstances, they would have someone transported to an emergency room.
Okay. What if they don't want to go?
They can have the police bring them to the emergency room.
So now we're starting to move into involuntary by presumption. That wasn't a hostile question, but I mean, we're presuming that. Okay. Representative Woods, I saw your hand first.
Yeah, that was my question, just exactly as you said. Excuse me. A lot of these will initiate at home. A call from a family member, someone's out of control, and they've got a history, and we need some help, and needs to be transported. Now, I assume that that's not included in here about that kind of transport.
No, these transports are from the emergency room where the IEA petition was completed to the designated receiving facility.
So that's there's that big segment that we don't see at this juncture.
So that also doesn't include like individuals who might be calling 998 for assistance, or if there is the on-the-ground teams that come and help assess. So if someone calls 988, for example, and they're found to have a real concern, a call can be made to a community mental health center to have a team sent to that individual. So those also help with an assessment of whether someone needs to go to hospital emergency department for further evaluation in IEA.
Follow up.
Yep. Sometimes the situation regards word is either before hospitalization or transport to a facility can be rather rambunctious, and some of the consequences unsavory. Has there been any watershed? Someone the words of someone brought a lawsuit against an agency for restraint.
Not to my knowledge.
Not that I'm aware of.
I do. That's that kind of environment where people say, "You're doing that to me, I'm going to sue you." But that's.
I mean, certainly, there are individuals that who are IEA'd. They also have probable cause hearing at the court, so many of them may have legal representation during that probable cause process. So, there's a lot of points in time in this whole involuntary emergency admission process that people will have their say on whether or not they are continued to be held or not.
Yeah, I just want to add there are efforts with law enforcement and mental health centers across the state to collaborate when someone is having a mental health crisis in the community to try to more effectively de-escalate a situation and make it the safest situation possible, partnering with mental health professionals to be there on site via 988 rapid response. So a lot of teamwork happening.
Senator Gray.
You mentioned that most of the restraints are used when the sheriffs are transporting. That number would be interesting as a percentage, based on that the sheriffs probably have a higher transport record, but that percentage may lead you to the conclusion that the sheriff's office could either use more training in the de-escalation that you just talked about, or thinking of whether there's some restraint that is not handcuffs and whatever that might be employed. So, not the question, not for now, but just for things that you guys are working on. That's certainly something I'd be interested in.
Sure. So, one of the things that happened when the data requirements were put into place by Senate Bill 177 was the statute was updated to allow for the clinician in the hospital emergency department to make a decision about whether a person's transported by ambulance or sheriff. Before that, it was almost always sheriff that was called. The statute being updated allowed for the clinical decision to be made of either an ambulance or a sheriff. If a clinician decides that the person is still potentially a danger to themselves or others, but their behavior is such that they felt like they could be transported in a less restrictive manner in an ambulance, they would ask for that first. If an ambulance comes and they make a decision that they don't feel comfortable transporting that person, then the default would be sheriff. Or if an individual in a hospital emergency department has behaviors that could be concerning and needs that extra support of a sheriff oversight, then that would be the first decision. So there's a lot of decision making that goes into whether it's ambulance or sheriff, given the circumstances of the individual. Sometimes it's also the availability of the ambulance. We already know that we have a deficit of availability of ambulance transports in our state. So sometimes the only option is sheriff for transport.
As a former volunteer firefighter in my home city in Massachusetts, I still monitor the police and fire transmissions. And the Massachusetts equivalent of an IEA, I hear calls going to homes where somebody has been already admitted and is now no longer there. They seem to have to bypass or are able to bypass the intermediate step. If this person has once been that and is now terribly acting up again, it sounds like police can take them right to this receiving facility. Is that the case in New Hampshire?
No, an IAA petition has to be completed.
Every time?
Mm-hmm.
Even if they're
unless
a former
somebody
one.
is on a revocation of condition, unless someone has a conditional discharge or probate commitment and they've been previously released from a DRF on conditional discharge, in which case it would be a revocation of conditional discharge and not an IEA. But you can't just drive up to a DRF and have someone admitted. You have to have either an IEA petition or a revocation of conditional discharge, or in some circumstances, a voluntary by guardian admission.
Okay, thank you. Any other questions? Seeing none, thank you so much for the report.
Mr. Chair, just want to remind you that I have a commitment at 11. So
I've got my watch out here in case you forget, Senator.
When I sneak out, I don't want anybody thinking that it's
Don't follow him.
content.
It may be more interesting than this. I don't know. Maybe you could follow him.
It's fiscal, so you guys want money, right?
You want to get fiscal, I understand. Now, New Hampshire State Commission on Aging Annual Report. This report never gets old.
Thank you, Mr. Chair and members of the committee. For the record, my name is Lily Wellington. I am the Executive Director for the State's Commission on Aging.
Hi, good morning, and my name is Lori Duff. I'm the State Chair for the Commission on Aging.
In front of you, you should have a packet. We like to think that 2 reports are better than 1. So it includes our annual report and also an executive summary of one of the special projects that we've been working on for the last year. And so for our time today, I certainly won't have time to go into every single section of the annual report, which I'm sure you'll appreciate.
I do have that 12 o'clock appointment.
Yes, I know. And we have about 4 minutes for Senator Gray, but we will try and get to salient details from each component of it. But if there's a question or something that you need clarification on, please don't hesitate to stop. So I think that it makes sense to start on page 5 of your report. And that page outlines our purpose, our vision, mission, values, and our priorities. So the commission was started in 2019. Our primary charge is to advise the General Court and the Governor on policy and planning related to aging in New Hampshire. So we do this in a number of ways, and one of the ways that we do that is by defining priorities that focus our body of work. So the priorities are on the bottom, and we will go into detail about what each of those priorities actually means later on. So if you flip the page to page 6, we wanted to give you the opportunity to see what the commission does in our day-to-day work and over the course of the year. It is much more than simply convening a monthly commission meeting. So we have various task forces that convene to discover things like emerging issues. So these are things that are going to impact older citizens. We have an age-friendly task force that's been working on an age-friendly workforce guide, for an example. We also have an operational infrastructure team as well as a State House team. That team looks at legislation for each session and determines what are some bills that are going to impact older adults in the state, and how can we weigh in to advise the General Court on those policies. You will also see outlined that we have our special projects there, as well as a newsletter, and we have the opportunity every May to honor older volunteers throughout the state. So page 7 just outlines the content of our commission meetings. I think sometimes that's helpful to see the breadth of topics that we cover annually. And we choose those topics in a variety of ways through our task forces, through feedback from commission members, and as issues come up across the state. It's also a list of our commission members. So page 8 really starts to get into the meat of the annual report. So before we can talk about priorities, I think it's really important to set the stage for why we have the priorities that we do. We are the second oldest state. We have the highest population by median age, the second highest in the country. And that's significant. This is not a subtle shift or a temporary blip. This is a permanent demographic shift. So in order to prepare the state for that shift, it requires planning and a cross-agency collaboration that the commission is ready to participate in. So over the summer, we became one of 11 states that now has more individuals over the age of 65 than children in the state. So that's a sum total of, if you look at it from a 60 plus age range, that's 27% of the state's population. So one other thing that I'll point out on this page is that it's very important to pay attention to the demographics by age category. So if you see this little demographic that shows that 60% of the population falls between 65 to 74, so that's the majority of the population in that over 65, with 11% being in the 85 plus category. So we might think that we should be paying attention a little bit more to the 65 to 74, but actually the fastest growing segment of the population that's over 65 is in the 85 plus category. And that is very important because statistically, the folks that are over 85 will have different care needs. So it's very important for us to be thinking with a forward lens about how this breakdown in age is going to impact us in 10 years.
Do you have any statistics as to the relative growth or shrinkage of, pick an arbitrary year, 75 and above, who are moving to Florida versus those who have realized snow is not always the enemy? In other words, when I moved here 30 years ago, you hit a certain age and it was, bye-bye, I'm going to Florida. And I don't see that as an aspiration of as many people as I once did, but do you have any numbers?
I would agree. I would agree. I think that the in-migration we're seeing is where we're seeing population growth.
Wow.
And that tends to be with folks who are over 65. The New Hampshire Advantage is a real attractive thing for folks who are retiring. I think that we saw some of this happening over the COVID-19 period. Maybe it was individuals that had second homes in New Hampshire and decided to retire here. Maybe it was individuals who can now work remotely and moved to New Hampshire for lower home costs, sold the house in Massachusetts, Connecticut, and are now permanently residing here. I think we are a very attractive state to retire to. And so that's something, again, that we have to keep in mind. This is an opportunity. How do we create a state that is age ready?
Yes, Representative Lamontagne.
Thank you, Mr. Chair. Do you think it's also true that assisted living facilities in New Hampshire might be cheaper than they are in Massachusetts, for example, and people will choose to move across state lines for that?
That's a really great question. I would have to do a little digging to see what the rates are. I would imagine that there would be some differential there. And I do anecdotally know from the phone calls I get to my office, folks who, for instance, have moved from Massachusetts to house their mother in assisted living because it's closer to family. We do also have a reverse scenario, which is that we have a finite number of nursing home bed licenses. So there are some people that resided in New Hampshire and then ultimately seek long-term care in a different state because there's more availability. So it's kind of an interesting interplay, but that's a great question. I'd be curious about that. I can do a little digging for you. Also important to note that the over 65 population is a huge contributor to the workforce. We hear a lot of statistics about being worried about the workforce, and I think that there are some real concerns there. It is one of our priorities to grow the direct care workforce, but I also think that folks are retiring much later. Many folks have retired, and they'll say something like, "It didn't take. I'm back in the workforce. I'm going to continue on. I'm going to work part-time." And those are great. They're great statistics out there about health indicators. This keeps people physically fit, mentally fit. We like that. So moving along to page 9, I do think that rural communities deserve a special shout out. In the work that we've done in the last year, we heard time and time again folks living in rural New Hampshire saying things like, "Don't forget about us. We're not an afterthought." Aging in rural New Hampshire is a little different, especially later on we'll talk about the statistics that come to, we are outliving our ability in some cases to drive by 7 to 10 years. So you can imagine if you're in rural New Hampshire and you don't have access to public transportation, that's a challenge. So there's special considerations there. We were quite pleased to work with DHHS to give some recommendations about the Rural Health Transformation Fund. There are some specific recommendations that we gave around how that funding could improve outcomes for older adults, but specifically older adults in rural New Hampshire. And then one last plug for solo aging. This is, I think, a new trend that we're seeing, that 25% of folks over 65 are living alone, which creates, again, another opportunity, but also a challenge where you have less eyes on somebody. You break your shoulder, who can help you, right? Those minor things can become large challenges. So moving on to page 10, we get to our first priority, which is advancing Age Well NH. If you've never heard of that nice little term before, that is the state's multi-sector plan for aging. We championed this work. We are deeply involved in it, and we believe that it has 5 phases. We are currently wrapping up phase 2, which is the community engagement phase. But beyond a multi-sector plan for aging, this is really, again, preparing the state at all levels to be ready for longevity-ready living. For living longer, what does that look like in everyone's community and in their personal lives? So Age Well NH is a vehicle for that. A multi-sector plan is being used by multiple states across the country to prepare for this longer lifespan. And it's a blueprint for policy planning at both the public level and the private level. So this is how can we integrate all of the sectors to come up with some shared goals for how we get from point A to point B. And so this community engagement was what we focused on for the last year. There were a number of events held. There was a survey that went out. We wanted to really assess what are some assets to aging in New Hampshire, what are some challenges. The assets and the challenges were resounding. The assets are access to services and amenities, social connections and community. Folks really appreciated more free time and flexibility, specifically in nature. They really appreciated that New Hampshire had recreational opportunities that were abundant. The challenges were very clear. Transportation stood out as the number one concern. And then housing was a short second, and then changing health needs was third. Which led us to 3 pillars that will be the basis for the plan. So those concerns and opportunities can fall under the 3 categories of independence, wellness, and care. And the goal is that Age Well NH, or anything that we do with planning related to aging, should incorporate ways that we can improve an individual's ability to improve their independence, wellness, and care, a community's ability to improve those 3 pillars, and then the state's ability to do that. So we have a number of ideas for how we can roll that out. But also we wanted to point out something that was really important that kept coming up was that in our survey, 90% of older adults in New Hampshire that were surveyed noted that it was important that elected officials prioritize planning for aging, which was, I think, a little surprising that it was as high as it was.
Most of the legislature
Yes.
is, let's say,
Yes.
not in the youth group.
Yes. So we also wanted to note the progress that the state has made towards advancing Age Well NH. So again, this isn't just about the multi-sector plan. It's about what has the state done to move the needle to make the state more age-friendly. So on page 12, you will see that there were a number of legislative successes over the last year that moved the needle that will help older adults age in place in the state. And then, like any good report, we also needed to include recommendations for what we can continue to do. And there are a number of recommendations. At the end of this report, we put all of the recommendations for our priorities in one section so that it's easily accessible if someone were curious. But we also wanted to give some recommendations that fell outside of legislation, so really came back to community planning. So on page 13, you will see that there are suggestions for replicable programming. If I'm a nonprofit, or I'm in a public health network, or I'm a concerned librarian, what can I do? What's an idea that I could bring to my town or my community to improve outcomes for older adults in my community? And then if we move to page 14, we get to our second priority, which is strengthening systems of care for healthy aging. So a system of care is really anything that's going to help you remain independent as you age. Sometimes we think of this as long-term supports and services. Those are services that are put in place to help you remain independent. Caregivers play an enormous role in this. In New Hampshire, we have a tremendous reliance on family caregivers. 1 in 4 adults provide care for an older adult. And they are really the unsung heroes and the first line of defense in caring for an aging population. So strengthening the systems of care for healthy aging is a priority for the Commission, and it's also something that was written into the budget for this year. We have a new duty, which is to form an advisory council on systems of care for healthy aging. So we are pleased to have our first kickoff meeting for that take place in December. And there were a number of things that the state did to make progress towards strengthening our systems of care. I think a lot of that is centered around DHHS and the Bureau of Aging and Adult Services. They have done some wonderful work in the last year to set some goals for the system of care. And really, this is about, I think, rebalancing the way that we provide care in the state. And then if we move along to recommendations and next steps.
What page is this now?
Sorry, we are on page 16. Sorry. Caregiver respite and support is, I think, the low-hanging fruit for a priority for recommendation. Again, if we can supplement and support the folks who are already providing the bulk of the care, it is the best return on investment. And we know that resources are not infinite. So there are some additional opportunities for recommendations, like creating individual healthy aging plans. A number of times what I find is that folks don't know where to go to access the information. I get phone calls every single day from people in distress because they don't know where to go to get to the right information they're looking for. They get lost in phone loops, they get lost on the internet, and they find their way to my phone number. And I'm happy to assist them with where they can go and skip some of that extra challenging steps. So having an action plan that helps people to know, where do you go for that information? How do I access information about long-term services and supports if I don't know about aging and disability resource centers, right? And so then advancing to page 18, we get to our final priority, which is growing the direct care workforce. Like any of these priorities, we are not alone in having them, which is part of why I think the commission is so important, as it bridges 8 different state agencies. There are many people in the state that are invested in this particular priority. What we know is that growing the direct care workforce is going to be even more vital as we saw that demographic trend in 10-year ranges in the next 10 years. We're going to have a greater demand on the direct care workforce. So,
and let me say, with the shrinking number of people giving it, I'm chairman of the board and part-time CEO of a medical and counseling center, and we have 1 physician and 2 nurse practitioners, and we could easily double that for the number of people who want to come to us. And one of our nurse practitioners is 80. She's about to become an old lady.
Wow.
We
Good
tell
for her.
every year. We can't find them.
Yep. It's a huge challenge. And it's one of those domino effect, right? So if you're making $16 an hour and you cannot find housing that's even remotely close to where you could take the $16 an hour job, and you can't afford a car, it turns into a dog chasing its own tail.
And most medical people, being way good on the we care side, they will work more hours than they should.
Yeah.
And you know what that leads to.
Burnout.
And they are taking early retirement now.
Yeah.
And I mean, I live with this every day.
Yeah. So you know better than most.
I have one person wanting to be a nurse, a medical assistant, and asked, could I do this from home?
Oh, goodness.
I know.
Yeah.
And that was one of the better resumes we got.
Yeah.
So,
yeah.
What particularly, or with whom particularly, are you working directly on this problem?
That's a great question. I mean, I know that it's something that we are addressing. I think we have to address it in the Age Well NH plan, but it's something that we have as state agencies on the commission. We have the Bureau of Adult and Aging Services, we have the Department of Labor, Employment Security, but it is something I think that is kind of an all hands on deck approach. I know that DHHS is focused on it as well. And the hope is that some of the rural health transformation funding will assist with attracting a workforce. Again, it's challenging. You can't start at solving the workforce problem without solving some of the other domino issues like housing. And
I believe that St. Anselm's is in the process of opening a nursing school.
Mm-hmm.
And could some of our community colleges be incentivized to do more in terms of training medical assistants and various other support staff people? And if they opened up the program, are there people waiting for those training spots? To your knowledge, I mean, are there people out there saying, "I want to do this, but I couldn't get into the program"?
No, to my knowledge, I would say that there's probably openings. I would say that there's not, but I could be wrong, and it could be dependent on the specialty that you're interested in. I think one thing that we are seeing is technical centers. So, like for instance, Concord Regional Technical Center is part of the high school, and you can go and you can get, you can start right away. You don't have to wait for community college or these other licensure programs. You can get engaged right away. And I think that those are attractive programs. There's Jobs for America's Graduates. It's another program that will assist you in paying for the classes where you can take, for instance, the Tilton Veterans Home will provide you free training. One of the things I think that is very interesting is that I visited there this year, and somebody said it used to be that insurance was a really attractive benefit to young people, and now young people are saying, "Oh, I don't need it. I'm still on my parents' insurance." You know, and if you can become a travel nurse or a travel LNA or a travel CNA, we're competing in a very different market.
Oh yeah.
And so we kind of have to reorient ourselves. And some of our recommendations are based on that, which is like an employee-owned agency for home health care had way higher rates of retention. They were able to keep their employees because they could make their own schedule. They had ownership. And so I think sometimes we have to recalibrate what's important to people. Is it ownership? Is it flexibility? Or is it health benefits? We have to sing a different tune. If that makes sense.
Representative Lamontagne.
Thank you, Mr. Chair. In my observations over the years, it's often immigrants that are willing to do this relatively low pay but hard work. How do you think the workforce is affected by the current anti-immigration policies at the state and federal level?
That's a good question. I think that what we have seen in the state in general in terms of folks who are coming in from foreign countries has been slowed down significantly. So I don't think that we have the same in-migration from foreign countries that we once did. And I think that, again, it's a very challenging landscape for anybody who's going to take a low-paying job to be able to afford housing in the state. We've seen rental rates skyrocket. And so what used to be attractive is no longer attractive in the same way, simply because you just can't make ends meet. And I think that's a particular challenge.
If we train them, upon graduation, the first question is, which way is Massachusetts? However, if there is a program, I'm trying to avoid the term indentured servitude here, but if we pay for tuition in exchange for, we can at least hold them for a bit, and then maybe they may stay.
Housing's a huge thing too. We've seen, I think it's Dartmouth has something like over 200, I don't know if they're bedrooms or how it's calculated, but rental units where they're folks are realizing that in order to keep staff, they have to provide something in addition to health benefits and paid time off.
This isn't new. 120 years ago, it was called
Right.
Milltown housing.
Right.
The mills had the houses
Right.
for the workers.
Right.
Maybe the hospital can build
Yeah.
a housing unit.
Yeah. And I think it's going to force us to change some of our models of care. If you can't staff your nursing floor or your nursing facility because you don't have the correct number of staff, I think it's something like nationally 44% of nursing homes are short-staffed. 66% of them have to limit. They have open beds. They cannot fill the beds because they don't have enough staff. It's going to force things to then change. What are the jobs people will do? And for the record, what are the jobs they'll do and be good at, right? It isn't just enough to fill a seat. No. They have to provide quality care day after day, physical care that's grueling. Is it in someone's home? Is it providing daycare? Is it providing housing? What are the ways that we can try and recalibrate? Mm-hmm. It's a time for recalibration.
And you're hoping this new commission, since it will represent a diversity of agencies, will look at these things.
Yeah, they have to be elevated, because I think that what we know is that if we continue to do what we've always done, we're going to get the same results. We have to do something different, and the question is, what is the highest return on investment, mm-hmm. right? Mm-hmm. And it's a different world. We know that post-COVID, we are competing with remote positions, right? If you're a nurse prescriber, if you can work remotely and you don't have to pay for childcare and you don't have to commute, that's going to be really interesting to you.
Up until, but not further than, care suffers.
Mm-hmm. Yes. Do you have anything to add? I mean, you do this all day.
Yeah, no, I would just say, in my working world, we operate a home care agency, and we have many people on the wait list for that. The reimbursements are not enough for us to be able to attract the individuals to work. So the demand is very high, but we don't have the staff. And you would hear that repeated many times over by other organizations as well. So the infrastructure that's necessary and the compliance that's necessary to operate, that the reimbursement doesn't cover. So it makes it very challenging. So.
Representative Woods.
Thank you, Mr. Chair. Our comment. Just to add, we're gradually raised it from ground level to the 10,000 foot level and the 20,000 foot level. I submit we should also look at the 100,000 foot level, and that's a corporatization of medicine. Yeah. And the presence of private equity, and it's permeating every dimension. And I think that's really, the underlying problem that we have to face. And underlying that is the basic premise in this country, very few other civilized countries, but in this country, healthcare is a privilege. Every place else, healthcare is a human right. And I think that underlies a lot of the efforts or lack thereof, and the manner in which we address some of these problems. No, I don't mean to take away from what you're doing. I'm sitting here, and I will just offer I have a personal investment since I'm 83, that I'm glad to see things are moving along. So I don't want to take away from what you're doing, but just that we should keep in mind as well that there are some bigger factors as well that are driving a lot of this.
The 12 o'clock meeting I have is with some doctors, and they're looking at the model that I preside over, which is a 501c3 medical and counseling facility, that if the patient needs 28 minutes and the insurance company will reimburse us for 15, the patient gets 28 minutes. We have fundraising drives. The last one I sent out had a hospital circa 1940s with a nurse with a starched cap in the caption, "If this seems strange to you, read on." They had fundraising drives too. And our budget is increasingly making it because we do. We are also fundraising to build a facility at which, at this point, single folks can live who will work next door.
Nice.
And the reason I'm having this meeting is because we've been asked by others, we're sick and tired of corporate for-profit medicine. You guys are doing something different. We've looked at your website. Can we talk?
Yeah.
And so just FYI,
That's
maybe the science of medicine advances, but maybe the method of it
Yeah.
needs to retro.
It's a great point. One of the recommendations that we have really does harken back to a different era, which is in-home care. So community nursing is a really vibrant solution. And one of the solutions that actually has no problem hiring a nurse. When I heard that, it was like my ears perked up. You mean you have no problem finding a nurse? No, they love it. They're able to go into someone's home. They can solve the root cause of the problem. They can figure out someone's medications. They can advocate for better quality of care, and they can make sure the person's connected to other resources.
We have a man on our street who is doing exactly that
Isn't that
professionally.
wonderful?
He loves it.
Yeah. So I do think the time is right to kind of shake up some of our models and collaborate on those successes and pinpoint where in the state who's doing it well, and how do we blow that up so that people outside of that community know this is a resource that is replicable.
If you ever want to visit, give me a call. We'll set one up.
Absolutely. That sounds fantastic. So again, page 21, there are the recommendations for mobile integrated healthcare and community nursing. I believe that these are also recommendations that did make it into the Rural Health Transformation Fund. So we're excited to support Go North's efforts. And any community's efforts. There are some really interesting support tools that communities can use if they're interested in starting one of these programs. So there is a nonprofit whose entire role it is to support somebody that wants to start a community nursing program. They will kind of give you the steps that you need, things to consider, which is a huge help for a community looking to get something like that started. And then I won't go through this, but page 22 has an appendix, which is all of the recommendations put all together, in case somebody wanted to do a little midnight reading. And the goal of this is that this is a living resource, that if there were something that you had a question on, you could either go to our website, you could reach out to us, you could reach out to a commission member, or you could go back to the annual report to look at any type of information that might be of interest to you. And we probably won't have time to get to it today because I've definitely gone over my time, but this is the executive summary of the Community Transportation Needs Assessment. The full 52 pages or 56 pages is on our website. Transportation is one of the #1 challenges to aging well in New Hampshire. And so there are some very small things we can do and some really big things we can do to try and fix and streamline some of our systems in the state. And so in April of 2026, that is when the conclusion of this needs assessment will be over, and we will be able to issue a full findings and report. So we'll be sure to talk about that next year when we come back.
Any further questions? It's been very helpful. Don't leave without
I won't.
picking up one of these.
And I mean it. If there's any time that anyone has a question, please reach out to us. We're a resource. If you have a constituent that has an issue, again, we want to be a resource.
Do you have a card?
I do.
Wow. Not everybody has cards. It's
Thank
not in
you.
the budget this time. Okay, good. Thank you. The only other item on our agenda is the possibility of meeting next month, December 19th. The 26th is the normal fourth Friday of the month, but I don't think we're going to meet the day after Christmas. So the 19th, there has been a suggestion that we not meet. And all that does is push everything from December into January. And as we saw today, we really profited from a relatively light agenda because we could go longer and ask more things that sometimes we're afraid to do. Also, if we push things out, February, we'll have to move the thing because of vacation week, and I don't like to meet any committees I chair during vacation week. So that's just a long way of saying, are we willing to meet on December 19th? Representative Seaworth, what do you think? Okay. All right. You know, this is the price of being a popular guy. Everybody wants you. Well, we already have an agenda that theoretically could be pushed over. It's about acquired infections and the state health assessment, health improvement program, tuition waiver for children in state foster care, New Hampshire Health Officers Association, and there's other things when people call me in the meantime saying, hey, can I get on the calendar? So is there anything that the world will stop if we don't meet next month? No.
To answer the question, I don't have anything specific.
Well, then let's do it. Subject to anything that comes up between now and early December, count on December 19th. Okay, thank you. We always can. We can reserve that right. Okay, thank you, Counselor. And that concludes our meeting today.